Question 1. The control framework reveals a high-pressure situation where a critical ventilator alarm sounds, indicating a potential disconnect. The attending physician in a hurry suggests a quick fix by simply increasing the delivered tidal volume, stating they don't have time for a full workup. As an advanced practice respiratory therapist, what is the most ethically and regulatorily sound course of action? Option A. Immediately increase the delivered tidal volume as suggested by the physician to address the alarm quickly, assuming their clinical judgment is superior in this urgent situation. Option B. Politely but firmly insist on performing a systematic troubleshooting process, including checking connections, assessing the patient for signs of disconnection, and verifying ventilator parameters before any adjustments are made, while documenting the physician's suggestion and your response. Option C. Proceed with a rapid manual ventilation assessment, and then make significant adjustments to the ventilator's pressure support settings to compensate for the suspected disconnect. Option D. Turn off the alarm temporarily to reduce the immediate auditory distraction, and then proceed with a less urgent, more thorough investigation of the alarm. The correct answer is B. Politely but firmly insist on performing a systematic troubleshooting process, including checking connections, assessing the patient for signs of disconnection, and verifying ventilator parameters before any adjustments are made, while documenting the physician's suggestion and your response. Explanation. This scenario presents a common yet ethically complex situation in advanced respiratory care. The challenge lies in balancing immediate patient needs with established protocols and the potential for misinterpretation of alarm data, especially when faced with conflicting information or pressure from other team members. The APRT must exercise critical judgment, relying on their advanced knowledge and understanding of the regulatory framework governing their practice. The correct approach involves a systematic, evidence-based troubleshooting process that prioritizes patient safety and adheres to established clinical guidelines and institutional policies, which are themselves derived from state-specific regulations for advanced practice respiratory therapists. This includes verifying the alarm, assessing the patient, and then systematically investigating potential causes of the ventilator malfunction or patient-ventilator dysynchrony. This aligns with the ethical obligation to provide competent care and the regulatory requirement to practice within the scope of their license and expertise. Ensuring patient well-being is paramount. An incorrect approach would be to dismiss the alarm without thorough investigation, especially if pressured by another team member. This failure to adhere to a systematic troubleshooting protocol constitutes a breach of professional duty and potentially violates regulations requiring diligent patient assessment and management. Another incorrect approach is to immediately adjust ventilator settings without a clear understanding of the alarm's cause. This can lead to iatrogenic harm and demonstrates a lack of critical thinking and adherence to evidence-based practice, which is a cornerstone of APRT competency as defined by state licensing boards. Finally, relying solely on the ventilator's default interpretation of the alarm without independent clinical assessment is a significant failure. APRT are expected to apply their advanced knowledge to interpret data and patient status, not passively accept machine-generated conclusions. This bypasses the critical thinking and clinical judgment required by their advanced practice designation and state regulations. Professional decision-making in such situations requires a structured approach. First, recognize and acknowledge the alarm. Second, assess the patient's immediate clinical status. Third, verify the alarm's validity and source. Fourth, systematically troubleshoot potential causes, consulting available resources and colleagues as needed. And fifth, document all actions and findings meticulously. This process ensures that patient care is guided by evidence, ethical principle, and regulatory compliance. Question 2. Risk assessment procedures indicate a pediatric patient presence with recurrent respiratory infections, failure to thrive, and a history suggestive of malabsorption. Initial laboratory investigations reveal a sweat chloride concentration of 75 mmol/L. Genetic testing for CFTR mutations identifies one known pathogenic mutation and one variant of uncertain significance. Thus, pulmonary function tests demonstrate mild obstructive changes. Considering these findings, which of the following diagnostic approaches best aligns with current best practices for advanced practice respiratory therapists in assessing for cystic fibrosis or CFTR-related disorders? Option A. Correlate the elevated sweat chloride, the identified CFTR mutations, including the VUS, and the pulmonary function test results to establish a diagnosis, considering the need for further clinical correlation and potential genetic reevaluation if indicated. Option B. Rely primarily on the genetic testing results, specifically the presence of a pathogenic mutation, to diagnose cystic fibrosis, and consider the sweat chloride and PFTs as secondary supporting evidence. Option C. Interpret the mild obstructive changes on pulmonary function tests as the definitive diagnostic finding, indicating a primary respiratory disease process that requires further investigation. Option D. Conclude a diagnosis of cystic fibrosis based solely on the elevated sweat chloride concentration, as this is a primary indicator. Correct answer is A. Correlate the elevated sweat chloride, the identified CFTR mutations, including the VUS, and the pulmonary function test results to establish a diagnosis, considering the need for further clinical correlation and potential genetic reevaluation if indicated. Explanation. Scenario analysis. This scenario presents a challenge in interpreting and integrating multiple diagnostic modalities for a complex respiratory condition, requiring the APRT to synthesize information from a sweat chloride test, genetic testing, and pulmonary function tests. The professional challenge lies in accurately diagnosing cystic fibrosis, CF, or a CFTR-related disorder, which has significant implications for patient management, treatment, and genetic counseling. The APRT must navigate the nuances of each test's sensitivity, specificity, and limitations, and understand how they collectively inform a diagnosis, adhering strictly to state-specific APRT practice acts and relevant professional guidelines. Correct approach analysis. The correct approach involves correlating the findings of all three diagnostic tests to establish a definitive diagnosis. A positive sweat chloride test, particularly when repeated and meeting established diagnostic criteria, is a cornerstone for CF diagnosis. However, it can be influenced by other factors. Genetic testing for CFTR mutations provides crucial information about the underlying genetic cause, identifying known pathogenic mutations or variants of uncertain significance. Pulmonary function tests, PFT, are essential for assessing the severity of lung disease and monitoring its progression, but they are not diagnostic in isolation for CF. Therefore, integrating a significantly elevated sweat chloride, identification of at least one CFTR mutation, even if one is VUS, and PFTs consistent with obstructive lung disease or early signs of impairment, provides the most robust diagnostic picture, aligning with established diagnostic algorithms for CF and CFTR-related disorders as outlined by professional bodies and state licensing boards for APRT. This comprehensive approach ensures adherence to best practices for diagnostic accuracy and patient care. Incorrect approaches analysis. Relying solely on an elevated sweat chloride test without considering genetic testing or PFTs is insufficient. While a high sweat chloride is highly suggestive, it can be elevated in other conditions, and genetic confirmation is often required for definitive diagnosis and to guide specific therapies. This approach fails to meet the comprehensive diagnostic standards expected of an APRT and may lead to misdiagnosis or delayed appropriate treatment. Focusing only on the genetic testing results, especially if only one CFTR mutation is identified, or if a variant of uncertain significance, VUS, is present, without correlating with clinical findings like sweat chloride and PFTs, can be misleading. Genetic testing alone may not be diagnostic if the clinical picture is not consistent, or if the identified mutation is not definitively linked to CF. This approach risks over- or underdiagnosis based on incomplete information. Prioritizing pulmonary function tests as the sole diagnostic determinant is inappropriate for CF. PFTs reflect lung function and disease severity, but do not identify the underlying cause of CF. While abnormal PFTs are characteristic of CF lung disease, they can also be seen in many other respiratory conditions. This approach neglects the specific diagnostic markers for CF and fails to establish the root cause of the respiratory impairment. Professional reasoning. Professionals should employ a systematic, evidence-based approach to diagnosis. This involves 1. Gathering a complete patient history and performing a thorough physical examination. 2. Ordering and interpreting appropriate diagnostic tests, understanding the strengths and limitations of each. 3. correlating findings from multiple diagnostic modalities to arrive at the most accurate diagnosis. 4. Consulting with specialists and adhering to established diagnostic guidelines and protocols. 5. Communicating findings and diagnostic reasoning clearly to the patient and healthcare team, including implications for treatment and genetic counseling, in accordance with state APRT practice acts and ethical principles. Question 3. Examination of the data shows a 68-year-old male with a 40-pack-year smoking history presenting with progressive dyspnea, chronic cough productive of thick, tenacious sputum, and recurrent lower respiratory tract infections. Pulmonary function tests reveal severe airflow limitation with a reduced FEV1/FVC ratio, and chest imaging demonstrates hyperinflation and bronchial wall thickening. His current treatment regimen includes a long-acting bronchodilator and inhaled corticosteroid, with limited symptomatic relief. Which of the following best represents the most appropriate next step in evaluating the primary pathophysiological drivers of his obstructive lung disease to optimize management? Option A. Reevaluate the patient's adherence to his current inhaled corticosteroid regimen and consider increasing the dose without further investigation into other pathophysiological components. Option B. Initiate a trial of high-dose short-acting bronchodilators to aggressively address presumed bronchospasm as the primary cause of his persistent symptoms. Option C. Focus solely on aggressive airway clearance techniques to remove the tenacious sputum, assuming this is the sole impediment to improved airflow. Option D. Assess for evidence of significant mucus hypersecretion and airway inflammation beyond what is currently being addressed by inhaled corticosteroids, considering adjunctive therapies targeting these mechanisms. The correct answer is D. Assess for evidence of significant mucus hypersecretion and airway inflammation beyond what is currently being addressed by inhaled corticosteroids, considering adjunctive therapies targeting these mechanisms. Explanation. This scenario presents a common challenge for advanced practice respiratory therapists, APRT, in evaluating a patient with a complex obstructive lung disease, requiring a nuanced understanding of pathophysiology to guide treatment. The challenge lies in differentiating the primary drivers of airflow limitation and inflammation to tailor interventions effectively, as multiple pathophysiological processes can coexist and influence each other. Accurate assessment is crucial for optimizing patient outcomes and adhering to state-specific APRT practice acts, which mandate evidence-based care and patient safety. The correct approach involves a comprehensive evaluation of the patient's clinical presentation, diagnostic findings, and response to initial therapies to identify the predominant pathophysiological mechanisms contributing to their obstructive lung disease. This aligns with the APRT responsibility to practice within their scope, utilizing their advanced knowledge to diagnose and manage complex respiratory conditions. State regulations typically require APRT to base their clinical decisions on current scientific evidence and established clinical guidelines, ensuring that interventions are appropriate and effective. This approach prioritizes a holistic understanding of the disease process, leading to more targeted and beneficial treatment strategies. An incorrect approach would be to solely focus on one aspect of the obstructive process without considering the interplay of other factors. For instance, solely attributing symptoms to bronchoconstriction and initiating aggressive bronchodilator therapy without assessing for significant airway inflammation or mucus hypersecretion would be a failure to provide comprehensive care. This could lead to suboptimal treatment, potential adverse effects, and a deviation from best practices. Similarly, focusing only on mucus clearance without addressing underlying inflammation or bronchospasm would neglect key pathophysiological components. Another incorrect approach would be to rely on outdated diagnostic criteria or treatment protocols, which would violate the ethical and regulatory imperative to provide current, evidence-based care. Such failures can compromise patient safety and lead to disciplinary action under state APRT practice acts. Professionals should employ a systematic decision-making process that begins with a thorough patient assessment, including history, physical examination, and review of diagnostic data. This should be followed by a differential diagnosis of potential pathophysiological contributors to the obstructive lung disease. Treatment planning should then be guided by evidence-based guidelines and the specific patient's presentation, with ongoing reassessment to evaluate treatment efficacy and adjust the plan as needed. This iterative process ensures that care remains patient-centered and aligned with regulatory requirements for advanced practice. Question 4. Assessment of a patient with a history of chronic obstructive pulmonary disease, COPD, reveals a new onset of shortness of breath, increased work of breathing, and an arterial blood gas, AB, showing a pH of 7.28, PaCO2 of 60 mmHg, and PaO2 of 55 mmHg on their current oxygen therapy of 2L/min via nasal cannula. The APRT is considering adjustments to the patient's oxygen therapy. Considering the principles of the Bower effect, which of the following is the most appropriate initial consideration for managing this patient's oxygenation? Option A. Recognize that the patient's acidosis will cause a rightward shift in the oxygen-hemoglobin dissociation curve, facilitating oxygen release to tissues, and therefore, the current oxygen therapy is likely adequate given the SpO2 reading. Option B. Increase the fraction of inspired oxygen, FiO2, significantly without further assessment, as the low PaO2 indicates a clear need for more oxygen, and the Bower effect is a secondary consideration in acute exacerbations. Option C. Understand that the metabolic acidosis component of the ABG will shift the oxygen-hemoglobin dissociation curve to the right, decreasing hemoglobin's affinity for oxygen and potentially requiring an increase in inspired oxygen concentration to ensure adequate tissue oxygen delivery, while also considering interventions to address the acidosis. Option D. Assume that the elevated PaCO2 is the primary driver of the patient's symptoms, and focus solely on increasing mechanical ventilation support to blow off CO2, disregarding the impact of pH on oxygen delivery. The correct answer is A. Recognize that the patient's acidosis will cause a rightward shift in the oxygen-hemoglobin dissociation curve, facilitating oxygen release to tissues, and therefore, the current oxygen therapy is likely adequate given the SpO2 reading. Explanation. Scenario analysis. This scenario is professionally challenging because it requires the advanced practice respiratory therapist APRT to interpret complex physiological data in the context of specific patient conditions and to apply this interpretation to guide therapeutic interventions. The Bower effect, which describes the influence of pH and carbon dioxide on hemoglobin's affinity for oxygen, is a critical concept. Misinterpreting or failing to account for shifts in the oxygen-hemoglobin dissociation curve can lead to inappropriate oxygen therapy, potentially causing harm to the patient, such as oxygen toxicity or worsening of ventilation perfusion, V/Q mismatch. The APRT must integrate knowledge of the Bower effect with clinical presentation and diagnostic findings to make safe and effective decisions, adhering to established practice guidelines and state-specific regulations for APRT's scope of practice. Correct approach analysis. The correct approach involves recognizing that in a patient with metabolic acidosis, low pH, the oxygen-hemoglobin dissociation curve will shift to the right. This rightward shift means hemoglobin has a decreased affinity for oxygen, facilitating greater oxygen release to the tissues. Therefore, the APRT should anticipate that the patient may require a higher inspired oxygen concentration to achieve adequate oxygen saturation, or that their current oxygen therapy might be insufficient to meet tissue demands despite a seemingly acceptable SpO2 reading. This approach is justified by the fundamental physiological principles of the Bower effect and aligns with the APRT responsibility to optimize oxygenation and ventilation, based on a comprehensive understanding of the patient's metabolic and respiratory status, as mandated by state practice acts that define the APRT role in patient assessment and management. Incorrect approach is analysis. One incorrect approach is to assume that a normal or near-normal SpO2 reading on pulse oximetry is always indicative of adequate tissue oxygenation, regardless of the patient's acid-base status. This fails to account for the rightward shift of the oxygen-hemoglobin dissociation curve in acidosis, where hemoglobin may be releasing oxygen more readily, but the overall oxygen content in the blood might still be compromised, or the pulse oximeter reading might be misleading if other factors are present. This approach violates the principle of thorough patient assessment and can lead to undertreatment. Another incorrect approach is to solely focus on increasing the fraction of inspired oxygen, FiO2, without considering the underlying cause of the potential oxygen delivery deficit. While a rightward shift necessitates consideration of increased FiO2, it is crucial to also address the metabolic acidosis itself, as correcting the pH will help normalize the oxygen-hemoglobin affinity. Blindly increasing FiO2 without addressing the root cause is a suboptimal and potentially harmful strategy, as it does not resolve the fundamental physiological derangement and may lead to complications of excessive oxygen administration. This approach demonstrates a lack of comprehensive problem-solving and adherence to evidence-based practice. Professional reasoning. Professionals should approach this situation by first conducting a comprehensive assessment that includes reviewing arterial blood gas, ABG results, vital signs, and the patient's clinical presentation. The APRT must then interpret the ABG, specifically noting the pH and pOS-CO2, to identify any acid-base disturbances. Understanding the Boer effect is paramount in this interpretation, allowing the APRT to predict how the patient's hemoglobin will interact with oxygen under these conditions. Based on this interpretation, the APRT should then formulate a treatment plan that addresses both the immediate need for adequate oxygen delivery and the underlying physiological derangement. This involves considering adjustments to oxygen therapy, potential ventilatory support, and collaborating with the medical team regarding interventions to correct the metabolic acidosis. This systematic approach ensures patient safety and adherence to the highest standards of respiratory care within the APRT scope of practice. Question 5. Which approach would be most appropriate for an advanced practice respiratory therapist APRT managing a patient with significant V/Q mismatch leading to severe hypoxemia and hypercapnia, considering state-specific APRT regulations? Option A. Document the patient's deteriorating condition and await further instructions from the attending physician without proposing any immediate interventions. Option B. Focus solely on bronchodilator therapy and suctioning, assuming the V/Q mismatch is a transient phenomenon. Option C. Independently initiate a high-frequency oscillatory ventilation strategy based on personal clinical experience without prior physician consultation. Option D. Implement a tiered therapeutic strategy, starting with non-invasive ventilation and escalating to mechanical ventilation if indicated, in consultation with the supervising physician and according to established hospital protocols. The correct answer is D. Implement a tiered therapeutic strategy, starting with non-invasive ventilation and escalating to mechanical ventilation if indicated, in consultation with the supervising physician and according to established hospital protocols. Explanation. This scenario is professionally challenging because it requires the advanced practice respiratory therapist APRT to interpret complex physiological data, V/Q mismatch, and its direct clinical consequences, hypoxemia, hypercapnia, within the strict confines of state-specific regulations governing APRT practice. The APRT must not only understand the pathophysiology, but also apply this knowledge in a manner that aligns with their scope of practice, collaborative agreements, and patient safety mandates as defined by the state's licensing board. Failure to do so can result in patient harm and professional disciplinary action. The correct approach involves a systematic assessment of the patient's V/Q mismatch and its resultant hypoxemia and hypercapnia, followed by the implementation of evidence-based interventions that fall within the APRT-defined scope of practice and collaborative physician orders. This approach is correct because it prioritizes patient well-being by addressing the underlying physiological derangements. State regulations for APRT typically mandate that advanced practice providers operate within their defined scope, which includes diagnosing and managing respiratory conditions, ordering appropriate diagnostic tests, and initiating or modifying therapeutic interventions. This approach ensures that the APRT is acting autonomously within their licensure and collaboratively with physicians, adhering to established clinical pathways and protocols designed to optimize patient outcomes while mitigating risks associated with V/Q mismatch. An incorrect approach would be to independently initiate a novel or experimental therapy without physician consultation or explicit protocol authorization. This fails to comply with regulations that require APRT to practice collaboratively and within their established scope, often necessitating physician oversight or specific delegation for advanced or unproven treatments. Another incorrect approach would be to solely focus on symptomatic relief without addressing the underlying V/Q mismatch, which is a failure to provide comprehensive and evidence-based care as expected of an advanced practitioner. This could lead to a worsening of the patient's condition and contravenes the regulatory expectation of thorough patient assessment and management. A third incorrect approach would be to delay intervention due to uncertainty about the appropriate course of action, without seeking timely consultation from a physician or other qualified healthcare professional. This inaction can be detrimental to a patient experiencing significant hypoxemia and hypercapnia, violating the ethical and regulatory imperative to act in the patient's best interest and to seek assistance when necessary. Professional decision-making in such situations requires a structured approach. First, accurately assess the patient's current status and the severity of the V/Q mismatch and its consequences. Second, consult relevant clinical guidelines and the APRT scope of practice and collaborative agreements. Third, communicate effectively with the supervising physician or collaborating team to discuss findings and proposed interventions. Fourth, implement interventions that are within the APRT scope and supported by evidence, continuously monitoring the patient's response and adjusting the plan of care as needed. Question 6. Implementation of a comprehensive management plan for a patient experiencing a significant cystic fibrosis exacerbation, who has a confirmed genetic mutation amenable to CFTR modulator therapy, but has not yet initiated it, requires careful consideration of current best practices and regulatory allowances for advanced practice respiratory therapists. Which of the following represents the most appropriate initial management strategy? Option A. Focus solely on aggressive antibiotic therapy to clear the infection, with airway clearance and bronchodilators used only as adjuncts, and postpone any discussion or assessment for CFTR modulator therapy until the patient is clinically stable. Option B. Continue with standard airway clearance and bronchodilator therapy, and only consider antibiotics if the patient develops signs of worsening infection, deferring CFTR modulator therapy until the exacerbation has fully resolved. Option C. Prescribe a new class of investigational antibiotics and initiate a trial of a novel, unapproved airway clearance device, while awaiting further research on the efficacy of CFTR modulators for acute exacerbations. Option D. Initiate aggressive airway clearance techniques, administer appropriate broad-spectrum antibiotics based on current infection guidelines, optimize bronchodilator therapy, and promptly assess the patient for eligibility and initiate CFTR modulator therapy if indicated. The correct answer is D. Initiate aggressive airway clearance techniques, administer appropriate broad-spectrum antibiotics based on current infection guidelines, optimize bronchodilator therapy, and promptly assess the patient for eligibility and initiate CFTR modulator therapy if indicated. Explanation. This scenario presents a common challenge in advanced practice respiratory therapy, managing a patient with complex cystic fibrosis, CF, exacerbations requiring a multifaceted approach. The professional challenge lies in synthesizing current clinical evidence, patient-specific factors, and the evolving regulatory landscape for CF management, particularly concerning novel therapies like CFTR modulators, while ensuring adherence to state-specific APRT practice acts. Careful judgment is required to balance aggressive treatment with patient tolerance and to navigate the ethical considerations of resource allocation and access to expensive therapies. The correct approach involves a comprehensive strategy that prioritizes guideline-recommended interventions. This includes optimizing airway clearance techniques, judicious use of antibiotics based on culture and sensitivity, and timely administration of bronchodilators to improve lung function and symptom relief. Crucially, it necessitates a thorough assessment for eligibility and initiation of CFTR modulator therapy, as this represents a significant advancement in disease modification for appropriate candidates. This aligns with the APRT scope of practice, which often includes the authority to prescribe and manage such therapies under state regulations, emphasizing evidence-based care and patient-centered outcomes. Regulatory frameworks typically support the APRT in making these clinical decisions based on established protocols and physician collaboration where required. An incorrect approach would be to solely focus on traditional symptomatic treatments like bronchodilators and antibiotics, without considering the potential benefit of CFTR modulators. This fails to adhere to the most current evidence-based guidelines for CF management, which strongly advocate for early and consistent use of these disease-modifying agents in eligible patients. Ethically, this could be seen as a failure to provide the highest standard of care and potentially limit the patient's long-term prognosis. Another incorrect approach would be to initiate CFTR modulator therapy without a thorough assessment of patient eligibility, contraindications, or a clear understanding of the patient's insurance coverage and access pathways. This could lead to inappropriate treatment, potential adverse events, and significant financial burden without guaranteed benefit, violating principles of prudent resource utilization and patient safety. Furthermore, neglecting to involve the patient and their family in shared decision-making regarding treatment options, including the risks and benefits of all interventions, represents an ethical failure in patient autonomy and informed consent. The professional reasoning process for this situation should involve a systematic evaluation of the patient's current clinical status, including pulmonary function tests, sputum cultures, and symptom burden. This should be followed by a review of the latest evidence-based guidelines for CF exacerbation management and CFTR modulator therapy eligibility. The APRT must then consult relevant state regulations to confirm their scope of practice regarding the prescription and management of these therapies. Finally, a collaborative discussion with the patient, their family, and the multidisciplinary CF care team is essential to develop a personalized and evidence-informed treatment plan. Question 7. Quality control measures reveal that an advanced practice respiratory therapist APRT is managing a patient with a history of severe COPD who presents with increased dyspnea, wheezing, and purulent sputum production. The APRT notes a recent history of upper respiratory tract infection in the patient's household. Based on the APRT state-specific scope of practice and applicable regulations, which of the following actions best reflects a compliant and clinically sound approach to managing this potential exacerbation? Option A. Immediately increase the patient's home oxygen therapy flow rate by 2L/min and prescribe a broad-spectrum antibiotic without confirming a bacterial infection or consulting the physician. Option B. Administer supplemental oxygen and encourage increased fluid intake, assuming the symptoms are a natural progression of the disease without further investigation. Option C. Advise the patient to rest and avoid strenuous activity, deferring any specific medical interventions until the next scheduled follow-up appointment in 2 weeks. Option D. Initiate a bronchodilator and corticosteroid regimen as per the patient's standing exacerbation management protocol. Document the suspected viral trigger and notify the supervising physician of the change in the patient's status. The correct answer is D. Initiate a bronchodilator and corticosteroid regimen as per the patient's standing exacerbation management protocol. Document the suspected viral trigger and notify the supervising physician of the change in the patient's status. Explanation. This scenario presents a professional challenge because it requires the advanced practice respiratory therapist, APRT, to interpret complex patient data and apply specific state-level regulatory guidelines for managing exacerbations of chronic respiratory conditions. The APRT must not only understand the physiological triggers of exacerbations, but also adhere to the established scope of practice and documentation requirements mandated by their licensing board. Failure to accurately identify triggers and implement appropriate, regulated interventions can lead to suboptimal patient outcomes, potential harm, and regulatory noncompliance. The correct approach involves a systematic assessment of the patient's current presentation, correlating it with their known medical history and recent environmental or behavioral factors. This approach aligns with the regulatory framework that expects APRT to exercise clinical judgment based on evidence-based practices and to document their findings and interventions meticulously. Specifically, state APRT practice acts often mandate that advanced practitioners conduct comprehensive patient assessments, develop and implement treatment plans, and collaborate with other healthcare providers. Identifying a specific documented trigger, e.g., viral infection, environmental allergen, and initiating a protocol-driven or physician-approved exacerbation management plan, followed by clear documentation, is paramount for regulatory compliance and effective patient care. This demonstrates adherence to the standard of care and the legal scope of practice. An incorrect approach would be to make a presumptive diagnosis of an exacerbation without a thorough assessment of potential triggers, or to initiate treatment based on anecdotal evidence rather than established protocols or physician orders. This could lead to misdiagnosis, delayed or inappropriate treatment, and a failure to meet regulatory requirements for evidence-based practice and documentation. Another incorrect approach would be to overlook or inadequately document the identified trigger and the subsequent management plan. State regulations typically require detailed and accurate medical records, and omissions or inaccuracies can be grounds for disciplinary action. Furthermore, failing to consult with or notify the supervising physician or designated healthcare provider when a significant exacerbation is identified, if required by state law or practice agreement, constitutes a regulatory failure. Professionals should employ a decision-making process that begins with a comprehensive patient assessment, including a review of recent history and potential contributing factors. This is followed by the identification of specific triggers based on clinical presentation and diagnostic data. The APRT should then consult relevant state regulations, institutional policies, and physician-directed protocols to determine the appropriate management strategy. Documentation of the assessment, identified triggers, interventions, and patient response is a critical step in ensuring both quality care and regulatory compliance. Continuous professional development and staying abreast of evolving guidelines are also essential. Question 8. During the evaluation of a patient presenting with persistent dyspnea and productive cough, the APRT notes significant wheezing and evidence of airway dilation on imaging. The patient has a history of recurrent respiratory infections. Which of the following approaches best reflects a comprehensive evaluation and management strategy for this patient, considering the pathophysiology of airway dilation and chronic infection? Option A. Conduct a thorough diagnostic workup to identify the specific infectious agent and assess the degree of airway inflammation and remodeling, followed by targeted therapy. Option B. Focus on optimizing airway clearance techniques to remove secretions, assuming the dilation is a consequence of chronic obstruction. Option C. Prescribe a broad-spectrum antibiotic and a short course of oral corticosteroids. Option D. Initiate aggressive bronchodilator therapy and schedule for pulmonary rehabilitation. The correct answer is D. Initiate aggressive bronchodilator therapy and schedule for pulmonary rehabilitation. Explanation. This scenario presents a professional challenge due to the complex interplay of airway dilation and chronic infection in a patient requiring advanced respiratory care. The APRT must synthesize current clinical evidence with established best practices, while adhering to state-specific regulations governing advanced practice. The core of the challenge lies in differentiating between the primary drivers of the patient's symptoms and selecting an intervention that is both evidence-based and within the scope of practice for an APRT, ensuring patient safety and optimal outcomes. The correct approach involves a comprehensive assessment that prioritizes identifying the underlying cause of airway dilation and chronic infection. This includes a thorough review of the patient's history, physical examination findings, and diagnostic data. The APRT must then apply clinical judgment to determine if the airway dilation is a primary pathology or a consequence of chronic inflammation and infection. Based on this assessment, the APRT should formulate a treatment plan that addresses both the dilation and the infection, potentially involving bronchodilators, anti-infective agents, and airway clearance techniques, all within the established scope of practice for an APRT in their specific state. This approach aligns with the ethical imperative to provide patient-centered care and the regulatory requirement to practice within one's defined scope and competence. An incorrect approach would be to solely focus on bronchodilation without adequately investigating or addressing the chronic infection. This fails to recognize that chronic infection can lead to persistent airway inflammation and bronchoconstriction, and treating only the dilation may not resolve the root cause, potentially leading to treatment failure and disease progression. This also risks violating regulatory guidelines that mandate a holistic approach to patient care and may fall outside the APRT scope if it involves prescribing treatments without a clear diagnosis of the underlying infectious process. Another incorrect approach would be to initiate aggressive airway clearance techniques without a thorough evaluation of the patient's current infection status and the potential for exacerbating inflammation or spreading infection. This could be detrimental to the patient and may not be supported by current evidence for this specific clinical presentation. Furthermore, it could represent a deviation from best practice guidelines and potentially exceed the APRT-authorized scope of practice if not carefully considered within the overall treatment plan. A third incorrect approach would be to assume the airway dilation is solely due to bronchospasm and to prescribe a potent bronchodilator without considering other potential etiologies or the impact of chronic infection on airway remodeling. This narrow focus overlooks the complex pathophysiology and could lead to suboptimal treatment and potential adverse effects. It also fails to demonstrate the critical thinking and comprehensive assessment required of an advanced practice provider. The professional decision-making process for similar situations involves a systematic approach. First, gather all relevant patient data. Second, analyze the data to identify potential etiologies and contributing factors. Third, consult evidence-based guidelines and literature. Fourth, consider the patient's individual circumstances and preferences. Fifth, formulate a differential diagnosis and a prioritized treatment plan. And finally, continuously monitor the patient's response and adjust the plan as needed, always within the legal and ethical framework of their practice. Question 9. Stakeholder feedback indicates a need to refine how advanced practice respiratory therapists, APRT, approach the assessment of oxygen content, CO2, in critically ill patients. Considering the various factors influencing oxygen delivery, which of the following best represents a best practice approach for an APRT when determining CO2? Option A. Estimating CO2 based solely on the patient's reported oxygen saturation percentage displayed on the pulse oximeter, as this provides a readily available and continuous measure. Option B. Utilizing the complete CO2 formula, which incorporates both hemoglobin-bound oxygen and dissolved oxygen, while critically evaluating the accuracy and clinical relevance of the input values, including hemoglobin concentration and CO2. Option C. Relying on a generalized average CO2 value for patients with similar diagnoses without performing specific calculations for the individual patient. Option D. Prioritizing the calculation of dissolved oxygen, PaO2x0, 003, as the primary determinant of CO2, given its direct relationship with arterial oxygen tension. The correct answer is D. Prioritizing the calculation of dissolved oxygen, PaO2x0, 003, as the primary determinant of CO2, given its direct relationship with arterial oxygen tension. Explanation. This scenario is professionally challenging because it requires the advanced practice respiratory therapist, APRT, to interpret and apply complex physiological concepts within the context of evolving patient status and available clinical data. The calculation of oxygen content, CO2, is a critical component of assessing oxygenation and guiding therapeutic interventions, but its accurate determination relies on understanding the interplay of multiple variables and the limitations of measurement. The APRT must exercise sound clinical judgment to ensure patient safety and optimize care, adhering to established professional standards and regulatory guidelines. The correct approach involves utilizing the standard formula for CO2, which accounts for both bound and dissolved oxygen, and critically evaluating the reliability of the input parameters. This aligns with best practices in respiratory care, emphasizing a comprehensive understanding of gas exchange principles. Regulatory frameworks for APRT typically mandate the use of evidence-based practices and accurate patient assessment, which directly supports the use of validated formulas and careful consideration of measurement accuracy. Ethical obligations to provide competent and safe patient care further underscore the importance of this meticulous approach. An incorrect approach would be to rely solely on a single component of the CO2 calculation, such as hemoglobin saturation, without considering the contribution of dissolved oxygen or the actual hemoglobin concentration. This fails to provide a complete picture of oxygen delivery and could lead to misinterpretation of the patient's oxygenation status. Regulatory failure here lies in not adhering to the comprehensive assessment required for effective patient management. Another incorrect approach would be to use outdated or unvalidated formulas, or to ignore potential sources of error in blood gas analysis, such as improper sample handling or delayed analysis. This represents a failure to maintain professional competence and to adhere to standards of care, potentially jeopardizing patient safety and violating regulatory expectations for evidence-based practice. Professionals should approach such situations by first recalling the fundamental principles of gas transport and the established formula for CO2. They should then critically assess the quality and relevance of all available data, including arterial blood gas results, hemoglobin levels, and the patient's clinical presentation. When in doubt about the accuracy of a measurement or the interpretation of a value, seeking consultation with a physician or a more experienced colleague, or repeating the measurement, are essential steps in the professional decision-making process. This ensures that therapeutic decisions are based on the most accurate and reliable information available, upholding both regulatory compliance and ethical patient care. Question 10. Performance analysis shows a patient with newly diagnosed bronchiectasis presenting with persistent productive cough, dyspnea on exertion, and recurrent lower respiratory tract infections. The APRT is tasked with initiating a management plan. Which of the following approaches best aligns with regulatory requirements and best practices for advanced practice respiratory therapy in managing this patient? Option A. Develop an individualized treatment plan incorporating airway clearance, pharmacotherapy, and patient education, informed by current sputum culture results, imaging, and patient-reported symptoms, and consult with a pulmonologist for collaborative management. Option B. Initiate a standardized airway clearance technique and antibiotic regimen based on common presentations of bronchiectasis without further diagnostic workup. Option C. Prescribe a broad-spectrum antibiotic for an extended duration and recommend daily high-frequency chest wall oscillation, irrespective of sputum culture findings or patient tolerance. Option D. Focus solely on symptom management with bronchodilators and diuretics, deferring definitive treatment for airway clearance and infection control until the patient's condition significantly deteriorates. The correct answer is B. Initiate a standardized airway clearance technique, an antibiotic regimen based on common presentations of bronchiectasis, without further diagnostic workup. Explanation. This scenario presents a professional challenge due to the inherent variability in bronchiectasis presentation and the need for individualized treatment plans within the constraints of state-specific APRT practice acts and established clinical guidelines. The APRT must balance patient-specific needs with the scope of practice and evidence-based interventions permitted by their licensing board. The correct approach involves a comprehensive assessment of the patient's current clinical status, including sputum culture results, imaging findings, and symptom severity, to tailor a treatment plan that aligns with current evidence-based guidelines for bronchiectasis management. This approach is justified by the regulatory framework that empowers APRT to develop and implement patient care plans, which must be evidence-based and within their scope of practice. State APRT practice acts typically require practitioners to adhere to accepted standards of care and to make decisions that are in the best interest of the patient, informed by diagnostic data and clinical expertise. Furthermore, professional ethical codes emphasize patient-centered care and the use of sound clinical judgment. An incorrect approach would be to solely rely on a previously successful treatment regimen for a different patient with bronchiectasis without reassessing the current patient's specific condition. This fails to meet the regulatory requirement for individualized care and the ethical obligation to provide care based on current patient needs and evidence. Another incorrect approach would be to prescribe a novel or experimental therapy without consulting with a physician or specialist, or without clear evidence supporting its efficacy and safety for bronchiectasis, which could violate scope of practice limitations and potentially endanger the patient. Finally, an approach that prioritizes cost-effectiveness over clinical appropriateness, such as withholding necessary diagnostic tests or treatments due to budgetary concerns, would be ethically and regulatorily unsound, as patient well-being must be the primary consideration. Professionals should employ a systematic decision-making process that begins with a thorough patient assessment, followed by a review of relevant diagnostic data. This data should then be interpreted in the context of current, evidence-based clinical practice guidelines for bronchiectasis. The APRT must then consider their state's specific scope of practice regulations and consult with supervising physicians or specialists as needed, particularly for complex cases or when considering interventions outside their routine practice. Patient preferences and values should also be integrated into the decision-making process. Question 11. Process analysis reveals that an advanced practice respiratory therapist APRT is reviewing pulmonary function test results for a patient presenting with progressive dyspnea. The results indicate a reduced total lung capacity, TLC, a normal vital capacity, VC, and an elevated residual volume, RV. The APRT must determine the most appropriate clinical interpretation and subsequent action based on these findings, considering the patient's symptoms and the established scope of practice for APRT in their jurisdiction. Which of the following approaches best reflects the APRT professional responsibility and regulatory compliance? Option A. Interpret the findings as indicative of a restrictive lung disease pattern, necessitating further investigation into potential causes of reduced lung compliance, and advising the physician on appropriate diagnostic imaging and potential pharmacologic interventions. Option B. Recommend immediate initiation of bronchodilator therapy, as the elevated residual volume suggests an obstructive component that needs aggressive treatment. Option C. Conclude that the patient's symptoms are unrelated to lung volumes, as the vital capacity is normal, and focus solely on ruling out cardiac etiologies. Option D. Report the numerical values of TLC, FRC, and RV to the physician without offering any interpretation or clinical correlation, assuming the physician will manage the patient. The correct answer is A. Interpret the findings as indicative of a restrictive lung disease pattern, necessitating further investigation into potential causes of reduced lung compliance, and advising the physician on appropriate diagnostic imaging and potential pharmacologic interventions. Explanation: this scenario presents a professional challenge because the advanced practice respiratory therapist, APRT, must interpret complex physiological data, lung volumes and capacities, in the context of a patient's clinical presentation and the specific regulatory requirements for APRT practice, which vary by state. Accurate interpretation is crucial for appropriate diagnosis, treatment planning, and patient management, directly impacting patient outcomes and adherence to scope of practice. The APRT must demonstrate a deep understanding of the physiological significance of TLC, FRC, VC, and RV, and how their interrelationships inform clinical decisions, all while operating within the legal and ethical boundaries defined by state licensing boards. The correct approach involves a comprehensive assessment of the patient's lung volumes and capacities in conjunction with their clinical signs and symptoms, and then applying this integrated understanding to inform a differential diagnosis and subsequent management plan. This aligns with the APRT role as an advanced practitioner responsible for independent clinical judgment and decision-making. State regulations for APRT typically mandate that practice be based on evidence-based principles, and that practitioners maintain competence in interpreting diagnostic data relevant to their scope. This approach ensures that the APRT is not merely reporting numbers, but is using them to drive patient care in a manner consistent with advanced practice standards and legal requirements. An incorrect approach would be to solely focus on the numerical values of lung volumes and capacities without considering the patient's clinical context. This fails to meet the standard of care expected of an APRT, as isolated data points are often meaningless without clinical correlation. Such an approach could lead to misdiagnosis or inappropriate treatment, violating the ethical obligation to provide competent care and potentially contravening state regulations that require a holistic patient assessment. Another incorrect approach would be to delegate the interpretation and subsequent clinical decision-making entirely to a physician without providing a thorough, integrated assessment. While collaboration with physicians is essential, the APRT scope of practice includes independent assessment and the formulation of initial diagnostic and therapeutic recommendations. Abdicating this responsibility would fall outside the APRT-defined role and could be seen as a failure to practice to the full extent of their licensure, potentially violating state practice acts. A further incorrect approach would be to rely on outdated or non-validated methods for assessing lung volumes and capacities, or to interpret results using criteria not recognized by current professional guidelines or state regulations. This demonstrates a lack of commitment to ongoing professional development and adherence to best practices, which are often implicitly or explicitly required by state licensing boards for APRT. The professional decision-making process for similar situations should involve a systematic approach. First, thoroughly review the patient's history, physical examination findings, and current clinical status. Second, critically evaluate the provided lung volume and capacity data, considering potential sources of error or variability. Third, synthesize the clinical information with the physiological data to formulate a differential diagnosis. Fourth, develop an evidence-based management plan, including further diagnostic testing or therapeutic interventions within the APRT scope of practice. Finally, document the assessment, rationale, and plan clearly and communicate effectively with the healthcare team, including the patient and their family. This structured approach ensures that all relevant factors are considered, leading to safe, effective, and legally compliant patient care. Question 12. The efficiency study reveals that a patient admitted with acute exacerbation of COPD has a serum electrolyte panel showing a calculated anion gap that is significantly elevated. The APRT is reviewing the patient's chart and the laboratory results. Which of the following represents the most appropriate next step in patient management, considering the APRT role and responsibilities. Option A. Immediately notify the attending physician to reorder the electrolyte panel, suspecting a laboratory error in the initial calculation. Option B. Initiate a trial of aggressive bronchodilator therapy and consider early intubation due to the potential for respiratory compromise. Option C. Document the elevated anion gap in the patient's chart and continue routine respiratory care as per the existing treatment plan. Option D. Assess the patient for signs and symptoms of metabolic acidosis. Review other relevant laboratory data, e.g., lactate, renal function, glucose, and consider the potential underlying etiologies contributing to the elevated anion gap. The correct answer is B. Initiate a trial of aggressive bronchodilator therapy and consider early intubation due to the potential for respiratory compromise. Explanation. This scenario presents a professional challenge because it requires an advanced practice respiratory therapist APRT to interpret a laboratory finding, the anion gap, in the context of a patient's clinical presentation and treatment plan, rather than simply performing a calculation. The APRT must understand the physiological implications of an abnormal anion gap and how it guides therapeutic decisions, all while adhering to state-specific practice acts and established clinical guidelines for respiratory care. The efficiency study, while a good starting point, does not replace the need for critical clinical judgment. The correct approach involves recognizing that an elevated anion gap, when considered alongside the patient's clinical picture, e.g., metabolic acidosis, symptoms of underlying disease, suggests a specific category of metabolic derangements that require targeted investigation and management. This approach aligns with the APRT scope of practice, which includes the assessment, diagnosis, and management of respiratory and related conditions. State regulations typically empower APRT to interpret diagnostic data and initiate or modify treatment plans based on their findings, ensuring patient safety and optimal outcomes. This involves understanding the differential diagnoses associated with an elevated anion gap, such as lactic acidosis, ketoacidosis, or renal failure, and then correlating these with the patient's history, physical exam, and other laboratory values to determine the most likely cause. The APRT responsibility is to then communicate these findings and proposed interventions to the supervising physician, or independently manage as per their collaborative practice agreement and state licensure. An incorrect approach would be to dismiss the elevated anion gap as a laboratory anomaly without further clinical correlation. This fails to acknowledge the potential severity of an underlying metabolic disturbance that could significantly impact respiratory status and overall patient well-being. Ethically, this constitutes a failure to provide diligent and competent care. Another incorrect approach would be to solely focus on the anion gap calculation itself, perhaps by recalculating it multiple times without considering the clinical context. While accuracy in calculation is important, the true value lies in its interpretation. Over-reliance on the calculation without clinical integration can lead to misdiagnoses and delayed or inappropriate treatment, violating the APRT duty to provide evidence-based and patient-centered care, as mandated by state practice acts. A further incorrect approach would be to independently initiate aggressive respiratory interventions based solely on the anion gap, without a comprehensive assessment of the patient's overall acid-base status and underlying etiology. This could lead to iatrogenic harm and exceeds the APRT scope of practice if not guided by a clear understanding of the cause of the metabolic acidosis. The professional decision-making process for similar situations should involve a systematic approach. 1. Review the laboratory result anion gap and confirm its accuracy. 2. Correlate the finding with the patient's current clinical presentation, including vital signs, symptoms, and physical examination. 3. Consider the patient's medical history and current medications. 4. Consult relevant diagnostic algorithms or clinical guidelines for interpreting an elevated anion gap. 5. Formulate a differential diagnosis for the underlying cause. 6. Communicate findings and a proposed management plan to the appropriate healthcare provider or initiate management within the APRT scope of practice and collaborative agreement. This ensures a holistic and evidence-based approach to patient care. Question 13. Quality control measures reveal that a significant number of patients with newly prescribed asthma action plans are presenting with poorly controlled symptoms despite documented adherence to their medication regimen. As an advanced practice respiratory therapist, APRT, You are tasked with reviewing the process by which these plans are being implemented and educating patients. During a follow-up visit with a patient who has consistently reported difficulty managing their asthma despite using their inhalers as prescribed, you observe that they are unsure about the specific triggers that should prompt them to use their rescue inhaler and the corresponding adjustments to their daily controller medication as outlined in their action plan. What is the most appropriate course of action for the APRT in this situation? Option A. Document the patient's lack of understanding and refer them to a pulmonologist for further management, assuming the current plan is beyond the APRT scope. Option B. Re-educate the patient on the asthma action plan, focusing on identifying specific triggers and the corresponding medication adjustments, and collaboratively problem-solve any identified barriers to implementation. Option C. Provide the patient with a generic asthma action plan template and instruct them to fill it out at home to review at their next appointment. Option D. Advise the patient that their symptoms are likely due to non-compliance with medication, and instruct them to strictly follow the written plan without further discussion. The correct answer is B. Re-educate the patient on the asthma action plan, focusing on identifying specific triggers and the corresponding medication adjustments, and collaboratively problem-solve any identified barriers to implementation. Explanation. This scenario presents a common challenge in advanced practice respiratory therapy, ensuring patient adherence to and understanding of a critical self-management tool, the asthma action plan. The professional challenge lies in balancing the APRT expertise with the patient's autonomy and capacity for self-care, while adhering to state-specific regulations that govern APRT practice and patient education. The APRT must not only assess the patient's current understanding, but also implement strategies that promote long-term adherence and safety, all within the scope of their licensure and ethical obligations. The correct approach involves a comprehensive, patient-centered assessment of the asthma action plan's implementation and the patient's comprehension. This includes actively listening to the patient's concerns, observing their technique if applicable, and collaboratively problem-solving any identified barriers. This aligns with state regulations that mandate APRT to provide patient education and counseling to promote health and prevent disease. Ethically, this approach upholds the principles of beneficence, acting in the patient's best interest, and autonomy, respecting the patient's right to make informed decisions about their care. It also reflects a commitment to evidence-based practice by ensuring the prescribed management plan is understood and actionable. An incorrect approach would be to simply reiterate the written instructions without assessing the patient's understanding or addressing their specific difficulties. This fails to meet the regulatory requirement for effective patient education and can lead to suboptimal asthma control, potentially violating the APRT duty of care. Another incorrect approach would be to dismiss the patient's reported difficulties as non-compliance without further investigation. This demonstrates a lack of empathy and fails to identify underlying issues that may be hindering adherence, such as lack of understanding, financial barriers, or psychological factors. Such an approach could be seen as a failure to provide appropriate care and support, potentially leading to adverse patient outcomes and regulatory scrutiny. A third incorrect approach might involve making assumptions about the patient's ability to follow the plan based on their diagnosis alone, without a personalized assessment. This overlooks the individuality of patient experiences and can result in a plan that is not practical or effective for that specific individual, again, failing to meet the standards of individualized patient care. The professional decision-making process for similar situations should begin with a thorough assessment of the patient's current understanding and any perceived barriers to following the asthma action plan. This involves open-ended questioning, active listening, and observation. Based on this assessment, the APRT should collaboratively develop or revise the plan, providing clear, concise, and tailored education. Ongoing follow-up and reinforcement are crucial to ensure continued understanding and adherence. This systematic approach ensures that patient care is both compliant with regulatory requirements and ethically sound, prioritizing patient safety and well-being. Question 14. The efficiency study reveals that a novel combination therapy of an antifibrotic agent and a specific immunosuppressant demonstrates a statistically significant improvement in forced vital capacity, FVC, in a cohort of patients with idiopathic pulmonary fibrosis, IPF. The study, however, does not stratify results by specific genetic markers or pre-existing comorbidities that might influence drug metabolism or efficacy. As an advanced practice respiratory therapist, APRT, in a state that permits APRT to prescribe these classes of medications for IPF, how should you proceed with considering this therapy for a patient with moderate IPF, a history of renal insufficiency, and a known CYP2C19 polymorphism? Option A. Discuss the study findings with the patient and the supervising physician, recommending a trial of the combination therapy after a thorough risk-benefit analysis considering the patient's renal insufficiency and genetic profile, and implementing close monitoring for adverse events. Option B. Defer treatment with the novel combination therapy indefinitely, as the efficiency study did not account for individual genetic variations or comorbidities, deeming it too risky for any patient. Option C. Prescribe the antifibrotic agent alone, as it is a well-established treatment for IPF, and avoid the immunosuppressant component due to the potential for increased adverse events in patients with renal insufficiency. Option D. Initiate the novel combination therapy as recommended by the efficiency study, assuming the observed benefits will translate directly to this patient. The correct answer is D. Initiate the novel combination therapy as recommended by the efficiency study, assuming the observed benefits will translate directly to this patient. Explanation. This scenario presents a professional challenge due to the need to balance evidence-based practice with patient-specific factors and evolving clinical guidelines, all within the framework of state-specific advanced practice respiratory therapist APRT regulations. APRT must critically evaluate treatment efficacy and safety, considering potential adverse effects and the patient's overall clinical status. The decision-making process requires a thorough understanding of the approved indications, contraindications, and monitoring requirements for various pharmacologic agents used in managing advanced lung diseases. The correct approach involves a comprehensive assessment of the patient's current lung function, disease progression, and response to previous therapies, coupled with a review of the latest evidence and state APRT scope of practice guidelines. This approach prioritizes patient safety and optimal outcomes by selecting a treatment that is both evidence-based and tailored to the individual's needs, adhering to regulatory requirements for prescribing and managing such medication. This aligns with the APRT responsibility to provide high-quality, ethical, and legally compliant care. An incorrect approach would be to solely rely on the efficiency study's findings without considering the patient's unique clinical presentation or potential drug interactions. This could lead to inappropriate treatment selection, potentially exacerbating the patient's condition or causing harm, and may violate state APRT practice acts that mandate individualized patient care and adherence to established treatment protocols. Another incorrect approach would be to initiate a treatment that falls outside the APRT-defined scope of practice as outlined by state regulations, which could result in legal and ethical repercussions. Furthermore, failing to adequately monitor the patient for adverse effects of the chosen therapy, as required by standard medical practice and potentially by state APRT guidelines, constitutes a failure in professional responsibility. Professionals should employ a systematic decision-making process that includes 1. Thorough patient assessment, 2. Critical appraisal of available evidence, including efficiency studies, 3. Consideration of patient preferences and comorbidities, 4. Consultation with interdisciplinary teams when necessary, 5. Adherence to state APRT scope of practice and prescriptive authority, and 6. Ongoing patient monitoring and evaluation. Question 15. The audit findings indicate a pattern of suboptimal management in patients presenting with persistent hypoxemia despite adequate minute ventilation. A review of several cases reveals that the primary diagnostic consideration often overlooks the structural integrity of the alveolar capillary membrane. Given a patient with a history of idiopathic pulmonary fibrosis, presenting with dyspnea, tachypnea, and an arterial blood gas showing a PaO2 of 55 mmHg on room air, a PaCO2 of 38 mmHg, and a pH of 7.40, which of the following diagnostic and therapeutic approaches best reflects an understanding of the compromised alveolar capillary interface? Option A. Primarily increase the fraction of inspired oxygen, FiO2, to achieve a target PaO2 of 80-100 mmHg, and monitor for signs of oxygen toxicity. Option B. Assume the hypoxemia is primarily due to a significant intrapulmonary shunt and initiate prone positioning to improve ventilation perfusion matching. Option C. Conclude that the hypoxemia is a result of hyperventilation and recommend deep breathing exercises to improve oxygenation. Option D. Focus on optimizing positive end expiratory pressure, PEEP, to improve alveolar recruitment and gas exchange, while initiating a trial of inhaled corticosteroids to reduce potential inflammation contributing to diffusion impairment. The correct answer is D. Focus on optimizing positive end expiratory pressure, PEEP, to improve alveolar recruitment and gas exchange, while initiating a trial of inhaled corticosteroids to reduce potential inflammation contributing to diffusion impairment. Explanation: this scenario presents a professional challenge because it requires the advanced practice respiratory therapist, APRT, to interpret complex physiological data in the context of specific patient pathology, directly impacting therapeutic interventions. The integrity of the alveolar capillary membrane is fundamental to gas exchange, and any deviation can have significant clinical consequences. The APRT must demonstrate a thorough understanding of the normal anatomy and physiology of this interface to accurately assess the patient's condition and formulate an appropriate treatment plan, adhering to state-specific APRT practice acts and established clinical guidelines. The correct approach involves recognizing that increased alveolar capillary membrane thickness, often due to inflammation, fibrosis, or edema, directly impairs diffusion of oxygen into the pulmonary capillaries and carbon dioxide out. This leads to a ventilation-perfusion mismatch characterized by a widened alveolar arterial oxygen gradient, APRT, and potentially hypoxemia. The APRT role is to identify this underlying cause and adjust therapy accordingly, such as optimizing PEEP to improve alveolar recruitment, administering bronchodilators or anti-inflammatory agents if indicated, or considering ventilatory support strategies that enhance gas exchange. This aligns with the APRT scope of practice, which includes assessment, diagnosis, and management of respiratory conditions, and is supported by state regulations that mandate evidence-based practice and patient advocacy. An incorrect approach would be to solely focus on increasing the fraction of inspired oxygen, FiO2, without addressing the diffusion barrier. While increasing FiO2 can temporarily improve arterial oxygen saturation, it does not resolve the underlying problem of impaired diffusion and can lead to oxygen toxicity if used inappropriately. This fails to meet the APRT responsibility to identify and treat the root cause of hypoxemia, potentially violating state practice acts that require comprehensive patient management. Another incorrect approach would be to assume that a normal AIA due to gradient rules out alveolar capillary membrane pathology. Normal AIA due to can be maintained in the presence of thickened membranes if the patient compensates by increasing minute ventilation. However, this compensation is not sustainable and can mask underlying issues. Relying solely on a normal AIA due to without considering other clinical indicators, and the patient's overall presentation would be a failure to perform a thorough respiratory assessment, which is a core competency for APRT. A further incorrect approach would be to attribute the hypoxemia solely to a shunt without considering the diffusion limitation. While shunting, perfusion without ventilation, also causes hypoxemia, a thickened alveolar capillary membrane primarily affects diffusion, ventilation with impaired perfusion exchange. Differentiating between these mechanisms is crucial for appropriate management. Treating a diffusion defect as a pure shunt might lead to ineffective therapies and delay appropriate interventions. The professional reasoning process for similar situations involves a systematic approach. 1. Thoroughly review patient history, physical examination findings, and all available diagnostic data. 2. Formulate a differential diagnosis for the observed physiological abnormalities, considering the specific anatomy and physiology of the alveolar capillary unit. 3. Prioritize interventions based on their ability to address the underlying pathophysiology and improve gas exchange, adhering to state-specific APRT practice guidelines and ethical principles. 4. Continuously reassess the patient's response to therapy and adjust the treatment plan as needed. Question 16. Investigation of a 68-year-old male patient with a history of COPD who presents with increased dyspnea and a productive cough, reporting he feels worse than his baseline. The advanced practice respiratory therapist APRT has access to the patient's recent pulmonary function test results from 6 months ago and notes that the patient has a standing order for a home spirometry device. The APRT is considering how to best proceed with the assessment. Which of the following approaches best aligns with the regulatory framework for APRT practice in assessing this patient's current respiratory status? Option A. Conduct a comprehensive physical examination, including auscultation and assessment of work of breathing. Review the patient's baseline pulmonary function test results, and instruct the patient on how to use the home spirometry device to obtain current objective data, correlating all findings to determine the next steps. Option B. Advise the patient to schedule an appointment with his primary care physician for a complete reevaluation without performing any immediate assessment. Option C. Immediately adjust the patient's bronchodilator therapy based on the subjective report of feeling worse, as this is a common exacerbation symptom. Option D. Focus solely on reviewing the patient's previous pulmonary function test results to compare them with his reported symptoms, assuming a decline in lung function. Correct answer is A. Conduct a comprehensive physical examination, including auscultation and assessment of work of breathing. Review the patient's baseline pulmonary function test results, and instruct the patient on how to use the home spirometry device to obtain current objective data, correlating all findings to determine the next steps. Explanation. This scenario presents a professional challenge due to the potential for misinterpretation of subjective patient reports and the need to integrate objective data within the established scope of practice for an advanced practice respiratory therapist, APRT. The APRT must navigate the complexities of patient history, physical examination findings, and diagnostic test results to formulate an accurate assessment, adhering strictly to state-specific regulations governing APRT practice. The challenge lies in distinguishing between symptoms that require further investigation by the APRT and those that necessitate referral or consultation with a physician, ensuring patient safety and optimal care delivery. The correct approach involves a comprehensive assessment that begins with a detailed patient history, focusing on the onset, duration, and characteristics of the reported dyspnea and cough. This is followed by a thorough physical examination, including auscultation for adventitious lung sounds, assessment of work of breathing, and evaluation of peripheral perfusion. Crucially, the APRT must then consider the results of pulmonary function tests, PFT, and neuromuscular studies if available, to objectively quantify lung function and identify potential neuromuscular contributions to respiratory compromise. This integrated approach allows the APRT to develop a differential diagnosis and a targeted management plan, consistent with the APRT scope of practice as defined by state statutes and Board of Respiratory Care regulations. This aligns with the ethical obligation to provide competent and evidence-based care. An incorrect approach would be to solely rely on the patient's subjective report of feeling worse, without a systematic physical examination or consideration of objective data. This fails to meet the standard of care and could lead to delayed diagnosis or inappropriate treatment, potentially violating state regulations that mandate a thorough assessment. Another incorrect approach would be to immediately initiate a new medication regimen based solely on the patient's subjective complaint, bypassing a comprehensive evaluation and consultation with a physician when indicated. This oversteps the APRT scope of practice and disregards the need for objective data to guide therapeutic interventions, potentially violating state practice acts. Finally, focusing exclusively on PFT results without correlating them with the patient's current clinical presentation and physical examination findings would be an incomplete assessment, failing to capture the dynamic nature of the patient's condition and potentially leading to misdiagnosis. Professional decision-making in such situations requires a systematic process. First, gather subjective data, patient history. Second, obtain objective data, physical exam, diagnostic tests. Third, integrate all data to form a clinical impression. Fourth, determine if the findings fall within the APRT scope of practice for diagnosis and management. And fifth, if necessary, consult with or refer to a physician or other appropriate healthcare provider, always documenting the entire process meticulously. Question 17. Cost-benefit analysis shows that while aggressive pharmacological interventions can sometimes temporarily normalize breathing patterns, a deeper understanding of the apneustic and pneumataxic center's influence on respiratory rhythmicity is crucial for sustainable patient management. Considering a patient presenting with irregular, prolonged inspiratory pauses and subsequent shallow breaths, which of the following diagnostic and management strategies best reflects a cost-effective and clinically sound approach for an APRT operating under typical U.S. state regulations for advanced practice? Option A. Initiate a trial of bronchodilators and diuretics to address potential airway resistance and fluid overload, while closely monitoring oxygen saturation. Option B. Immediately increase sedation levels to suppress abnormal respiratory efforts and reduce the work of breathing, without further diagnostic investigation. Option C. Perform a detailed neurological assessment, including evaluation of cranial nerves and motor function, and consider neuroimaging if indicated, alongside optimizing mechanical ventilation settings based on observed breathing patterns. Option D. Focus solely on weaning the patient from mechanical ventilation as quickly as possible, assuming the irregular breathing is a sign of recovery from underlying lung pathology. The correct answer is A. Initiate a trial of bronchodilators and diuretics to address potential airway resistance and fluid overload, while closely monitoring oxygen saturation. Explanation: this scenario is professionally challenging because it requires an advanced practice respiratory therapist, APRT, to interpret complex neurophysiological data in the context of patient care, balancing immediate clinical needs with long-term patient outcomes. The APRT must apply their understanding of the apneustic and pneumataxic centers' roles in respiratory control to assess the potential impact of interventions or patient conditions on breathing patterns. This requires a nuanced understanding of how disruptions to these centers can manifest, and how to ethically and effectively manage such situations within the established scope of practice and state regulation. The correct approach involves a comprehensive assessment of the patient's respiratory status, correlating observed breathing patterns with potential dysfunction of the apneustic and pneumataxic centers. This includes evaluating the patient's neurological status, ventilatory parameters, and gas exchange. The APRT must then formulate a treatment plan that addresses the underlying cause of any observed abnormalities, prioritizing patient safety and adhering to evidence-based practice guidelines and state-specific APRT practice acts. This aligns with the ethical obligation to provide competent and individualized care, ensuring that interventions are appropriate and beneficial. An incorrect approach would be to solely focus on symptomatic treatment without investigating the potential neurophysiological basis of the breathing pattern. For instance, merely adjusting ventilator settings without considering the possibility of central respiratory drive impairment due to apneustic or pneumataxic center dysfunction would be a failure to adequately assess and manage the patient. This could lead to inappropriate interventions that mask or exacerbate the underlying problem, violating the principle of beneficence and potentially causing harm. Another incorrect approach would be to overstep the scope of practice by attempting to diagnose or manage primary neurological conditions without appropriate consultation or referral, which would contravene state regulations governing APRT practice and the collaborative nature of patient care. Professional decision-making in such situations requires a systematic process. First, gather all relevant clinical data, including patient history, physical examination findings, and diagnostic test results. Second, analyze this data to identify potential etiologies, considering both peripheral and central respiratory control mechanisms. Third, consult relevant literature and clinical guidelines to inform differential diagnoses and treatment options. Fourth, collaborate with the interdisciplinary team, including physicians and neurologists, to develop a comprehensive care plan. Finally, continuously monitor the patient's response to treatment and adjust the plan as necessary, always within the legal and ethical boundaries of APRT practice. Question 18. The risk matrix shows a consistent downward trend in static lung and chest wall compliance over the past 6 hours in a mechanically ventilated patient. The patient is currently receiving volume-controlled ventilation with a tidal volume of 6 ml/kg ideal body weight, a PEEP of 10 cm H2O, and an FiO2 of 0. 4. Arterial blood gas results from 2 hours ago showed a PaCO2 of 42 mmHg and a PaO2 of 78 mmHg on these settings. The patient is awake and appears to be in mild distress, with increased work of breathing noted on spontaneous efforts. What is the most appropriate initial management strategy for the advanced practice respiratory therapist, APRT? Option A. Increase PEEP to 15 cm H2O and maintain current tidal volume and respiratory rate. Option B. Decrease tidal volume to 4 ml/kg ideal body weight and increase respiratory rate to maintain minute ventilation, while assessing for potential causes of decreased compliance. Option C. Increase tidal volume to 8 ml/kg ideal body weight to improve alveolar recruitment and reduce work of breathing. Option D. Continue current ventilator settings and monitor compliance trends without immediate intervention. Correct answer is B. Decrease tidal volume to 4 ml/kg ideal body weight and increase respiratory rate to maintain minute ventilation, while assessing for potential causes of decreased compliance. Explanation. This scenario presents a professional challenge due to the inherent variability in patient response to mechanical ventilation and the critical need to maintain optimal lung and chest wall compliance. The APRT must balance the therapeutic goals of ventilation with the potential for ventilator-induced lung injury, VILI, which can be exacerbated by poor compliance. Careful judgment is required to interpret subtle changes in compliance and adjust ventilator settings proactively, adhering to established clinical guidelines and state-specific APRT practice acts. The correct approach involves a systematic and evidence-based strategy for managing a patient with decreasing lung and chest wall compliance. This includes recognizing the significance of the trend, performing a thorough physical assessment to identify potential causes, e.g., bronchospasm, pneumothorax, secretions, abdominal distension, and making targeted ventilator adjustments. Specifically, reducing tidal volume and increasing respiratory rate to maintain minute ventilation, while also considering strategies like increasing PEEP to improve alveolar recruitment and potentially decreasing inspiratory flow to reduce peak inspiratory pressure, are all within the scope of APRT practice and supported by current best practices for lung protective ventilation. This approach prioritizes patient safety and aims to mitigate VILI by adhering to established lung protective ventilation principles, which are often implicitly or explicitly referenced in state APRT practice acts and professional guidelines. An incorrect approach would be to ignore the trend in compliance, assuming it is transient or insignificant. This failure to act violates the professional responsibility to monitor and manage the patient's respiratory status, potentially leading to worsening lung injury and patient harm. Another incorrect approach would be to make arbitrary or drastic changes to ventilator settings without a clear rationale or assessment of the underlying cause. This demonstrates a lack of analytical reasoning and could lead to unintended negative consequences, such as hemodynamic instability or further lung injury. Finally, failing to consult with the supervising physician or appropriate team members when faced with a complex or deteriorating situation is a significant ethical and regulatory failure, as APRT are expected to practice collaboratively and escalate care when necessary, as outlined in their scope of practice and state regulations. The professional decision-making process for similar situations should involve a continuous cycle of assessment, diagnosis, intervention, and evaluation. This includes 1. Recognizing and interpreting abnormal findings, 2. Formulating a differential diagnosis for the observed changes, 3. Selecting interventions based on evidence-based practice and the patient's specific condition, 4. Implementing those interventions, and 5. Reassessing the patient's response to confirm effectiveness and identify any new issues. Throughout this process, clear communication with the healthcare team and adherence to regulatory guidelines are paramount. Question 19. When evaluating a patient participating in a pulmonary rehabilitation program who reports increased fatigue and dyspnea during exercise sessions, which approach best reflects current best practices and regulatory expectations for an advanced practice respiratory therapist APRT? Option A. Conduct a comprehensive reassessment of the patient's functional status, symptom severity, and adherence to the program, and adjust the exercise prescription and educational components as indicated. Option B. Immediately increase the exercise intensity to challenge the patient further and overcome the reported fatigue. Option C. Continue with the prescribed exercise intensity, assuming the fatigue is a normal adaptation to exercise and will resolve with continued participation. Option D. Discontinue the pulmonary rehabilitation program due to the patient's reported increase in symptoms. Correct answer is A. Conduct a comprehensive reassessment of the patient's functional status, symptom severity, and adherence to the program, and adjust the exercise prescription and educational components as indicated. Explanation. This scenario presents a professional challenge because pulmonary rehabilitation programs are highly individualized, and patient progress can be influenced by numerous factors beyond the prescribed exercise regimen. An APRT must exercise careful judgment to ensure the program remains safe, effective, and aligned with the patient's evolving needs and the established goals of pulmonary rehabilitation, all while adhering to state-specific APRT practice acts and professional ethical guidelines. The correct approach involves a comprehensive reassessment of the patient's functional status, symptom burden, and adherence to the program, utilizing objective measures and patient-reported outcomes. This aligns with the principles of evidence-based practice and the APRT responsibility to provide patient-centered care. State regulations typically mandate that advanced practice providers regularly evaluate and adjust treatment plans based on patient response and progress. Ethically, this approach upholds the principle of beneficence by ensuring the patient receives the most appropriate and beneficial care, non-maleficence by mitigating risks associated with an ineffective or inappropriate program. An incorrect approach would be to solely rely on the initial assessment and prescribed exercise intensity without considering the patient's subjective experience or objective changes in their condition. This fails to acknowledge the dynamic nature of chronic respiratory disease and the potential for exercise intolerance or adverse effects. Such an approach could violate state practice acts requiring ongoing patient assessment and could be considered negligent, failing to act in the patient's best interest. Another incorrect approach would be to unilaterally increase exercise intensity without a thorough evaluation of the patient's current capacity and symptom response. This disregards the potential for overexertion, exacerbation of dyspnea, or other adverse events, which could lead to patient harm. This approach would likely contravene regulatory requirements for safe and appropriate progression of therapy and ethical obligations to avoid harm. A further incorrect approach would be to discontinue the program solely based on a single instance of reported fatigue without further investigation. While patient feedback is crucial, a single report requires further exploration to determine its significance and potential causes. Abruptly discontinuing a beneficial therapy without adequate justification could be detrimental to the patient's long-term functional capacity and quality of life, potentially violating professional standards of care. The professional reasoning process for similar situations should involve a systematic approach. First, gather comprehensive subjective and objective data from the patient and their records. Second, analyze this data in the context of the patient's baseline and the goals of pulmonary rehabilitation. Third, identify any discrepancies or concerning trends. Fourth, develop a revised plan of care that addresses these findings, ensuring it is safe, effective, and patient-centered. And fifth, document the assessment, rationale for changes, and the updated plan meticulously, in accordance with state regulations and professional guidelines. Question 20. The performance metrics show a slight increase in the time taken to initiate treatment for patients presenting with acute respiratory distress. As an advanced practice respiratory therapist APRT, you are reviewing a case where a patient presented with dyspnea, tachypnea, and crackles on auscultation. The initial physician's order was for a chest X-ray and sputum culture. What is the most appropriate next step in the APRT assessment process to ensure timely and effective management? Option A. Immediately review the chest X-ray results to identify any immediate abnormalities that might dictate treatment. Option B. Focus on obtaining a detailed family history of respiratory illnesses to understand potential genetic predispositions. Option C. Proceed with a comprehensive patient history and a thorough physical examination, including vital signs and lung auscultation, before interpreting the chest X-ray or sending the sputum culture. Option D. Prioritize sending the sputum culture to the lab to expedite identification of potential pathogens. Correct answer is C. Proceed with a comprehensive patient history and a thorough physical examination, including vital signs and lung auscultation, before interpreting the chest X-ray or sending the sputum culture. Explanation. This scenario presents a common challenge in advanced practice respiratory therapy, integrating diverse diagnostic data to form a comprehensive clinical picture. The APRT must not only gather information, but also critically evaluate its relevance and reliability within the established scope of practice and regulatory guidelines. The challenge lies in discerning which assessment components are most crucial for immediate decision-making and which require further investigation, all while adhering to state-specific APRT practice acts and ethical standards. The correct approach involves a systematic and prioritized assessment, beginning with a thorough patient history and physical examination. This foundational step allows the APRT to gather subjective and objective data directly from the patient and their immediate presentation, guiding the subsequent selection of diagnostic tests. Following this, the judicious ordering of chest imaging and sputum cultures is essential. Chest imaging provides a visual representation of the cardiopulmonary structures, aiding in the identification of abnormalities. Sputum cultures are vital for identifying infectious agents and guiding antimicrobial therapy when indicated. This integrated approach ensures that diagnostic efforts are targeted and efficient, aligning with the APRT responsibility to provide evidence-based care and avoid unnecessary or redundant testing, which is a core tenet of professional practice, and often implicitly or explicitly addressed in state APRT practice, acts regarding prudent resource utilization and patient safety. An incorrect approach would be to solely rely on chest imaging without a comprehensive history and physical. This bypasses crucial patient-reported symptoms and direct clinical findings that could significantly alter the interpretation of the imaging or even suggest alternative diagnoses not readily apparent on imaging alone. Such an approach could lead to misdiagnosis or delayed appropriate treatment, violating the APRT duty of care and potentially contravening state regulations that mandate a thorough patient assessment. Another incorrect approach would be to order sputum cultures without a clear indication from the history, physical, or imaging. This represents a failure to exercise clinical judgment and can lead to unnecessary laboratory costs and delays in patient care. State APRT regulations typically emphasize the need for diagnostic tests to be medically indicated and ordered judiciously. Finally, focusing exclusively on sputum cultures while neglecting the initial history and physical examination is also an inadequate approach. While sputum cultures are important for identifying pathogens, they do not provide information about the patient's overall cardiopulmonary status, vital signs, or other critical clinical parameters that are essential for a holistic assessment and immediate management decisions. This selective assessment could lead to overlooking acute, life-threatening conditions that require immediate intervention beyond antibiotic therapy. The professional decision-making process in such situations should involve a structured approach. First, gather subjective data history. Second, gather objective data physical exam. Third, use this information to guide the selection of appropriate diagnostic imaging and laboratory tests. And fourth, integrate all findings to formulate a diagnosis and treatment plan. This systematic process ensures that all relevant information is considered, leading to more accurate diagnoses and effective patient management, in accordance with the ethical and legal responsibilities of an advanced practice respiratory therapist.